Okay. Ever had that split second where your knee just feels like it's going to buckle? Maybe during a quick turn playing sports or even just, stepping awkwardly.
Hmm.
That feeling of instability, it can be really unsettling. And it's often the first clue to what we're really getting into today. Anterior Cruciate Ligament, or ACL, tears.
Exactly. Yeah, and think of the ACL as one of the major anchors inside your knee, providing that crucial stability. So in this deep dive, we're pulling apart all the key info about ACL tears from our notes,
Yeah.
giving you a clear and, really importantly, high-yield understanding. Think of this as your kind of go-to audio guide for revision.
Our mission today is pretty straightforward.
Okay.
Give you the complete picture on ACL tears, starting with the definition, what triggers them, all the way through how they're spotted, what can be done, and what to expect down the line.
Hmm.
We'll try and keep it jargon light, focus on what truly matters so it all sticks. Ready to jump in?
Absolutely. Yeah, let's kick off with the fundamental question. What exactly is an ACL tear? Well, at its heart, it's a tearing or overstretching of this really important ligament.
Yeah.
These injuries usually happen because of sudden, powerful movements that the ligament just, well, can't handle.
Okay, so when you say sudden, powerful movements,
Yeah.
what does that actually look like in real life?
Yeah, good question. We often see this in non-contact situations, which might be surprising to some people.
Yeah.
Think about suddenly slamming on the brakes while running or sharply changing direction with your foot firmly planted. Another common one is what we call a valgus twisting injury.
Mm-hmm.
Sort of imagine your knee collapsing inwards.
Ah,
Then there's hyperextension, where your knee gets forced straight beyond its normal range, a sharp internal twisting of your lower leg, or even just a really rapid slowing down, pure deceleration.
right, I can picture some of those.
Mm.
So what sets this whole chain of events in motion? What are the main sort of causes?
Well, the causes really mirror those mechanisms we just talked about. So sudden stops, changes in direction, twisting, that hyperextension, they're all major triggers.
Mm-hmm.
Direct hits to the knee can do it too, especially common in sports that involve jumping and quick pivots. And it's a key point to remember, female athletes do have a higher risk.
Ah, yes, you mentioned that.
And this is thought to be related to differences in anatomy, maybe hormonal factors as well.
That's interesting about the increased risk for female athletes. Is there like a particular reason why?
Well, the exact reasons are still being studied, but it's thought that differences in knee anatomy, muscle strength patterns around the knee, and maybe the way women tend to land and move can all play a role.
I see.
And hormonal fluctuations, they might also affect ligament laxity, potentially making them a bit more susceptible to injury at certain times.
Okay. That gives a bit more context.
Yeah.
So are there specific things that make someone more prone to an ACL tear? Like, what are the risk factors we should keep in mind?
Definitely. If you participate in sports with lots of quick changes in direction or jumping, think football, basketball, netball, skiing, your risk goes up significantly.
Right, makes sense.
As we touched on, being female is a key risk factor. Having a previous ACL injury, on either knee actually, also makes you more vulnerable.
Oh, really? Even the other knee?
Yeah. And things like not using proper landing techniques after a jump or having imbalances in the strength of the muscles around your knee joint, those can also contribute.
So we know what an ACL tear is, what causes it, who's more at risk.
Mm-hmm.
But what's actually happening inside the knee when the ligament tears? What's the pathophysiology?
Basically, when the stress on the ACL goes beyond its breaking point, the collagen fibers that make up the ligament start to tear. This can be a partial tear or, a complete rupture.
Okay.
And the big consequence is that your knee joint loses a significant amount of its stability. The ACL is just crucial for controlling how much your lower leg rotates and how much it slides forward relative to your thigh bone.
Right.
When it's damaged, that control is, well, gone. And unfortunately, the force of the injury can often lead to damage in other parts of the knee, too, like those cartilage shock absorbers.
Oh, the meniscus, yeah.
Exactly. And the articular cartilage, which is that smooth surface on the ends of your bones, that can get damaged, too.
So if someone comes in with these kinds of problems, what else could it be? What's the differential diagnosis? What other conditions might look similar?
Yeah, it's important to think about other knee injuries that can present with similar symptoms. We definitely consider a tear of the posterior cruciate ligament, the PCL, which is another major stabilizer.
Okay.
Tears of the collateral ligaments, those are on the sides of the knee. Meniscal tears, like we just mentioned. Even a dislocated kneecap, a patellar dislocation, can cause pain and instability.
Got it.
And then you've got general instability in the knee from other underlying issues, and maybe even osteoarthritis, although that usually develops more gradually.
This sounds like a fairly common injury then. What does the epidemiology tell us? How often do ACL tears actually occur?
They are indeed one of the more common knee injuries we see, yeah, particularly here in the UK. And their occurrence is especially high in athletes, particularly those in the high-risk sports we've mentioned.
The cutting and jumping ones.
Exactly, the ones with rapid changes in direction, lots of jumping. So if you're involved in those activities, it's definitely something to be aware of.
Right. So if someone does tear their ACL, what are the typical things they're going to notice? What are the clinical features?
The clinical picture often includes a pretty distinctive popping sound, or sometimes just a sensation of something giving way right at the moment of injury.
The pop.
Yeah, the pop. And this is usually followed quite quickly by swelling around the knee, significant pain, and that feeling of instability we talked about. People often find it really difficult to put weight on the injured leg, and they might describe their knee giving way during everyday movements, even just walking or turning.
That giving way sensation really does highlight the instability, doesn't it? So how do healthcare professionals actually diagnose an ACL tear? What investigations are involved?
Okay, so the diagnosis usually starts with a thorough physical examination and a detailed discussion about how the injury happened. Getting that history is key.
Right.
Then imaging plays a vital role. MRI, magnetic resonance imaging, is really the gold standard here. It gives a clear picture of the ACL itself and lets us check for any other damage inside the knee.
And x-rays.
X-rays are less helpful for seeing the ACL directly, but we might use them if we suspect a fracture, maybe from a direct blow, to rule that out.
Okay. And what about those specific physical tests we often hear about, like the anterior drawer test and Lachman's test?
Yeah, these are crucial parts of the physical exam. For the anterior drawer test, the patient lies on their back, knee bent to about 90 degrees. The examiner holds the upper part of the lower leg, just below the knee, and gently pulls it forward. If there's excessive forward movement compared to the uninjured knee, that suggests an ACL tear, more laxity.
Right, more give. And the Lachman's test. Similar idea.
Similar idea, but often considered more sensitive, especially soon after injury. For Lachman's, the knee is bent less, maybe only 15 to 20 degrees. The examiner stabilizes the thigh with one hand, pulls the lower leg forward with the other while pushing the thigh back. Again, you're looking for increased forward movement or that feeling of looseness compared to the other side. That indicates an ACL injury.
And the pivot shift test, that one sounds a bit more complex.
It is a bit more involved, yeah, and sometimes harder to do if the patient is in pain or guarding. For the pivot shift, the examiner internally rotates the patient's foot and lower leg, applies a gentle inward, or valgus, force to the knee, and then slowly straightens it from a bent position, maintaining that internal rotation.
And what are you looking for?
A positive test is often indicated by a palpable or sometimes even visible clunk or sudden shift. That's the tibia reducing back into place relative to the femur because the ACL isn't there to control that rotational movement properly.
Got it.
And just to reiterate on imaging, while x-rays are mainly for ruling out fractures, MRI is really the go-to for seeing the ACL and any meniscus or cartilage damage. But it's worth noting the accuracy of these physical tests can vary, depends on swelling, muscle guarding, how soon after the injury it is, and the examiner's experience too.
Okay, that makes sense. So we've got a diagnosis of an ACL tear. What happens next? What are the management options?
Right. How we manage an ACL tear really depends on a few key things. How bad the tear is, how active the person is, their age, their goals, and their overall health.
Right.
Initially, we might consider non-surgical treatment. So that involves things like rest, physiotherapy, maybe using a brace for support. However, for athletes, or really anyone who's still experiencing significant instability despite non-surgical efforts, surgery to reconstruct the ACL is often recommended.
Reconstruction, not repair.
Generally, reconstruction, yes. The ACL doesn't tend to heal well on its own. And regardless of whether someone has surgery or not, rehabilitation afterwards is absolutely essential. That's key to getting the knee working properly again.
Let's dive a bit deeper into those options. When would you typically lean towards surgery versus, say, just trying conservative management first?
Generally speaking, surgery is often recommended for younger, more athletic people. The main reason is to try and reduce the longer-term risk of further damage, like to the menisci and cartilage inside the knee.
Because of the ongoing instability?
Exactly. If the knee keeps giving way, it puts stress on those other structures. Conservative management, on the other hand, can be a perfectly good option for people who are less active or maybe whose symptoms aren't too severe, not causing major instability problems. The aims there are really to manage pain and swelling, keep the knee moving as much as possible, and strengthen those supporting muscles, especially the quadriceps.
And what does that non-surgical conservative management actually involve day to day?
It usually starts with controlling the initial pain and swelling. We often use the acronym PRICER, that's protection, rest, ice, compression, and elevation. Basic first aid, really.
Okay, Pricer.
Got it. Then the focus shifts to getting the muscles around the knee, particularly the hamstrings and quads, firing properly again. They can often become weak or inhibited after an injury like this. We typically use a hinged knee brace for some support while gradually starting protected weight bearing. As the pain and swelling settle down, we'd work on getting the full range of movement back.
And exercises.
Yeah, exercises are key, often starting with ones that involve straightforward and backward movements, things that don't put too much rotational stress on the knee, like using a stationary bike, for example.
Okay, that makes sense for the non-surgical row. What about the surgical side? What are the key things to consider there?
Well, surgical decisions are very much made on a case-by-case basis. It really depends on the person's sport or activity level, how often they do it, and how much instability, how much laxity they're actually experiencing.
Right.
Surgery, which, as we said, is usually reconstruction, is often considered once the initial swelling has gone down and the knee has regained a good range of motion. Going in too early can increase risks like stiffness.
Okay. And the surgery involves a graft.
Yes, for a complete ACL rupture, you need a graft because the torn ligament doesn't heal itself. We might use an autograft, which is tissue taken from the patient's own body, commonly from the patellar tendon below the kneecap, or hamstring tendons.
Yeah.
Or an allograft, which is donor tissue, usually from a cadaver.
Huh.
Both have pros and cons that need discussing with the patient.
That's a helpful overview. Now, I recall seeing something in our notes about a big review of the evidence, a Cochrane review. What did that tell us about surgery compared to just rehab?
Yes, that's a really interesting point. That Cochrane review, which pools together all the best available research, actually suggested that there's limited strong evidence to show that having surgery plus structured rehab leads to significantly better outcomes in terms of patient-reported knee function, how the knee feels and works to them at 2 and 5 years after the injury when compared to just having structured rehabilitation alone.
Wow, really? That's quite surprising.
It is. It really highlights just how crucial a good, dedicated rehab program is, regardless of whether surgery is performed or not. Rehab is non-negotiable, really.
That's a huge takeaway. So, thinking about outcomes then, what can someone expect after an ACL tear, both short and long term? What's the prognosis, and are there potential complications?
The outlook, the prognosis, it really varies quite a lot. It depends on how severe the initial injury was. Crucially, if there were any other structures damaged in the knee at the same time, like meniscus or cartilage tears.
Right, those associated injuries.
Exactly. And as we just emphasized, how committed the individual is to their rehabilitation. That's massive. With the right treatment and a really dedicated rehab effort, many people can get back to a good level of knee stability and return to their previous activities.
That's good news. But are there downsides?
Well, it's important to know that there is an increased long-term risk of developing osteoarthritis in the affected knee. That risk is definitely higher if there were other injuries at the time, or if the ACL tear wasn't properly addressed and led to ongoing instability.
Okay, osteoarthritis risk. And what about potential complications from the treatment itself? Anything to watch out for?
Yeah, there are potential complications. One is something called arthrofibrosis, which is basically when too much scar tissue forms in the joint, leading to stiffness. This can sometimes happen if surgery is done too soon after the injury, before the initial inflammation settles.
Oh.
It's also really important for patients to understand that surgery doesn't automatically guarantee that someone will be able to return to exactly the same level of sport or activity they were at before. Expectations need to be realistic.
Right.
There's also a known risk of re-injuring the ACL or injuring the ACL in the other knee, particularly in the period shortly after returning to sport. That's a vulnerable time. And as we've mentioned, that long-term risk of osteoarthritis remains a concern, and it might even be slightly higher if someone needs revision surgery down the line.
Okay. It's a lot of information to process. Definitely high yield, though.
Yeah.
Do we have any handy mnemonics or memory tips that could help us and our listeners remember some of the key things about ACL tears, especially for revision?
Absolutely. Always good to have some memory hooks. For recalling those common ways an ACL gets torn, those mechanisms, you could try thinking of twist. T for twisting, W for weak landing, I for impact, a direct blow, S for sudden stop, and T maybe for turn, sharp change of direction.
Twisting. Weak landing, impact, sudden stop, turn. Nice. What about symptoms?
For the main symptoms you might notice, think of POPS. P for pain, O for outward instability, that giving way feeling, P for pop heard or felt at the time of injury, and S for swelling.
POPS,
Yeah.
pain, outward instability, pop, swelling. That's great. And linking symptoms to what's happening.
Right. So that giving way sensation, that O in POPS, is a direct result of the ACL no longer doing its job stabilizing the knee, especially during those cutting or pivoting movements.
Makes sense.
And when you're trying to remember the Lachman's and anterior drawer tests, just visualize pulling the lower leg, the tibia, forward relative to the thigh, the femur. That abnormal forward movement is what you're looking for because the ACL leash is broken, so to speak.
Good visual. Any quick phrase for management?
Maybe something simple like, initial rice, rehab is key, repair for the unstable knee, just to cover the basics.
Initial rice, rehab is key, repair for the unstable knee. I like it. These memory aids are really useful. Okay, to help solidify things, let's try a couple of quick example questions, sort of MSRA style. For instance, if a young athlete, say 19 years old, has a suspected ACL tear after a football injury with immediate swelling and instability, what would be the most appropriate initial imaging modality?
Okay, based on our discussion, given the mechanism, age, and symptoms suggesting ligament and possible internal damage, an MRI would be the best initial imaging to properly assess the ACL and look for those associated injuries like meniscal tears or cartilage damage.
Right, MRI for the detailed look.
Yeah.
Okay, different scenario. What might be a typical first-line management strategy for, say, a 55-year-old individual with a confirmed ACL tear who is not very active, works a desk job, and doesn't report significant instability in daily life?
Yeah, in that scenario where the patient isn't highly active and isn't experiencing major functional instability, a trial of conservative management would likely be the most appropriate first step. So, focusing on pain and swelling control, physiotherapy to restore range of motion and strength, maybe activity modification. Surgery might be overkill initially.
Fantastic. Yeah, this has been a really thorough deep dive into ACL tears.
Yeah.
We've covered the definition, causes, risk factors, what's actually happening in the knee, other things it could be, how common it is, the signs, how it's diagnosed, the tests, management options, surgical and non-surgical, and then the prognosis and potential complications.
Yes, absolutely. The aim was really to give you a clear, high-yield overview for revision, hitting all those key points from the notes, and I think we've certainly covered a lot of important ground there.
Definitely. And if you listening are looking for even more resources to help with your MSRA revision, be sure to head over to passthemsra.com. They have a ton of materials specifically designed to support your studies.
Yeah, definitely check them out. And also, don't forget freemseries.com for additional free resources and helpful content as well. Worth a look.
Absolutely. Understanding the intricacies of the ACL is, well, it's a significant step in your learning journey. Keep exploring, keep asking questions, keep diving deep, and you'll master this and so much more.